Hey everybody, it's Daniel Bakken from Proactive Athletic Performance. And in this short video, what I want to do is go over what you'll get from us when you refer a patient in for testing. So first off, what you'll get, the first thing is going to be my PDF of all the results that I'm about to go over with you in the video. But it's going to go over, the quick subjective. And then I'm really not going to be doing a lot of range of motion or manual muscle testing, special tests. Unless you specifically ask me for that, I'm going to leave that up to you because you're already doing that with your patients. Essentially, what we're going to be doing is the force plate and the isokinetic or isometric strength tests on the HUMAC. So you'll get a written type up of my note. For that, I'll give you a quick assessment plan, things like that. But you can even take this note and put it in your patient's file, or you can even use this as part of your note to the doctor for discharge or progress note. You can even copy and paste it and put it directly in your note as well. Okay. The second thing you're going to get are going to be the reports themselves. And I'm going to go over these in a moment. The third thing, and I think the most important, is what you're watching right now, and that's the video breakdown of the findings. That way you don't have to study up and learn how to interpret these findings. I'll just kind of give that to you right there. And then you take these findings and these reports and you use that to either program the next phase of your rehab with the patient. You can use that to determine their plan of care for the next 4 to 6 week block. You can use that as your discharge planning, whether that's they continue with you, they come back in for retesting with me, or they go directly to their sport, or they're going to be working with their personal trainer. Essentially, you're just going to be taking the findings that I have and you're going to be implementing them. It's not that I'm going to be telling you specifically what to do. Unless you ask me any questions on things that we can do for it, I'm not going to overstep my bounds and tell you what to do. Okay. So this patient, she's 6 months out after an ACL with a quad tendon graft. Now, she also had the lateral articular tenodesis with the IT band. So, and she's actually home for the summer. She plays lacrosse at a major university, and she's rehabbing here for the summer. So her athletic trainer sent her in for testing, and then we were trying to determine, based on this testing, the best fit for her this summer. Is she only going to work with a personal trainer? Is she going to be working with somebody on the field? Is she going to be working with me? And what we ended up doing because of these findings is I'm working with her twice a week, 1 week, and then once a week the next week. And that gives her a chance to also work with her strength conditioning coach to alter her upper body, lower body, and core and conditioning days. So let's go over the findings with this. So this first report you're going to get is going to be an isometric test. And what we're looking at here, this is her quadriceps, correct? So this is a quadriceps. The right leg is going to be the blue lines. The left leg is going to be the red lines. Let's see. If you need to know which side is the involved side, you can always look up here at the top. So her involved side is the left side, but it's pretty obvious by her lines here. So with this being isometric, the y-axis is going to be torque. So the harder she pushes, the further up the lines are going to go. And the time is a 5-second time across that x-axis. And just looking at the graph, you can see her healthy leg, the right leg, it kicks up torque quickly and it levels off, right? Over here on her surgical side, she had a lot of graft site pain still on that quadriceps. And that's one of the things that her athletic trainer at the university had told me that they had been working on. Because of the amount of pain she was having, we didn't have her kick up into it when she did it. We had her build up that torque over about 1 second to 1.5 seconds. So that's why this is more of a slanted line versus more of a vertical line. Another thing looking at the graph is that she doesn't have a lot of oscillation. The little bits of oscillation you see here, that's normal. If somebody has really bad AMI, we will see a big wobble, a big sinusoidal or hertz going on, and the amplitude. And she doesn't have that. So now after looking at the graphs, then we go to the numbers. Over here, this is the peak torque in foot-pounds. So her right leg, the uninvolved side, hit 180 foot-pounds. Her left hit 104. So that gives her a 42% deficit. Now, this athlete, she weighs 155 pounds. So I always relate this back to the body weight. So even though we have that 42% strength deficit, Her right leg is hitting 116% of her body weight. And we say that for males, you want to have at least 1 foot-pound per pound you weigh. So that would be 100% of the body weight. For some females and for larger mass males, like if they're an offensive lineman, a basketball center, right? We usually allow down to 90%, but we always try to get at least 100% here, even for females. Her right leg is at 116% of the body weight. So it's above what it needs to be. A lot of times we'll see, especially early on at 3 months or so, that the uninvolved leg will drop a little bit, but it usually comes back up. Now her left leg, the surgical side, is at 67% of the body weight. And again, if I'm looking to get about 100% here, she's 67% of the way there. And even if we're just looking at the bilateral difference, she's 58% of the way there at 6 months out with that quad graft and that extra procedure. So I'm good with that. Next, we have the average torque, but I don't pay attention there. What I do look at next is, what is that torque at 200 milliseconds? Now, it's one thing for her to be able to build up that torque over a second or two, but you don't have a second or two when you're doing jogging, jumping, functional activities, sports. You have milliseconds. So we put a timestamp of what is that torque at 200 and 400 milliseconds. I pay more attention to the 200 milliseconds. So when we're looking at the total torque, like I said earlier, the peak, she's 42% different. But that torque at 200 milliseconds, now we have a 78% deficit. And that just comes down to the fact that she did not like loading that quadriceps quickly, okay? Next thing we look at is how much of their body weight can they do instantaneously. And that right leg is at 90%, that left is at 19%. Now, when it comes to jogging, I want them to be able to hit a total peak torque of at least half of their body weight, and she's there with that. But you can see with how much does she have access to right away. When she's easing into it, it's 19%. Now, I'm going to retest her in about another 2 weeks, and we've been working on that quadriceps loading. Just like you were, if you had this information, you would also implement these. But we're working on loading that quadriceps isometrically in that deep range so she adapts to it. I'm interested to see what her torque at 200 milliseconds will be in about 2 to 3 weeks and retest her. Lastly, what I look at for the quadriceps is what is their rate of torque development. And that's this initial slope. So what we do is we take the torque from 20 to 80% of their maximum, right? Cut out the bottom 20% because that's going to be squishing into the pad. We cut out the top 20% because that's going to be any additional torque they get after that initial slope, that incline. So with this, it reads in foot-pounds per second. I always tell patients this is miles per hour if they understand that a little better. So her healthy side is getting 504 foot-pounds per second. The left is at 59. So there's an 88% difference in rate of torque development. But that makes sense with the symptoms she was having. Again, when we retest her in about 2 to 3 weeks, that's going to be a lot different. Now I scroll down here. We're looking at the hamstrings. And if the patient had the hamstring graft, we would see a bigger deficit here and the smaller one in the quadriceps. Just keep that in mind. So you can see her left leg, the red lines, very close to what the right legs are visually on the graph. We go to the numbers, the peak torque, she's hitting 76 foot-pounds versus 66. So she's only at a 13% difference side to side with that bilateral difference. But when we go now to the percentage of body weight, we want this to be 50 to 60% of their body weight, depending on what their quadriceps is. For her, with her quadriceps being so strong, I want this to be at least 60% of her body weight. She's at 49 and 43. So that left hamstring is really doing well. It's about 60-ish% of the way there. On the right side, that will get stronger as we get her into more exercises. She really hasn't done a whole lot in terms of posterior chain work outside of the beginning rehab exercises. So I know these numbers are going to come up just as she moves on to that next level of strength conditioning with deadlifts, RDLs, Nordics, things like that. So slight weakness bilaterally in the hamstrings, even though she's at that 13% difference. Now, if somebody has a history of chronic hamstring strains or they had the hamstring graft, then I look more in depth at what is that torque at 200 milliseconds and what is the torque, that rate of torque development. But for most athletes who don't have those set of circumstances, I don't really pay attention to those because we're going to pick that up with our isokinetic test in just a moment. All right, so next, depending on where they are in their rehab, if they're at least 5 months out, I then can do the advanced isokinetic test. If they're only 4 months out, I'll do the standard isokinetic. But this one, the advanced test, this gives me concentric and eccentric data. So I really like to get this one, especially when they're nearing discharge from you. That way we can see what's going on with them. So on this report here, this is the quadriceps isokinetically. On this side here, we have the concentric quadriceps. On the right, we have the eccentric quadriceps. The left leg is the surgical side. It's always in the red lines. The right leg or healthy side, that's the blue lines. It's always going to be there. And if you didn't know what it is, it's right here on the bottom for you. What we're looking at on the graph, this is 90 degrees, right? So this is with the knee bent. Over here on the left, this is 10 degrees. So when we go from the right side to the left side of the graph, that's straightening out concentrically. And what we're seeing is that with the knee bent and with the knee straight, you're not as strong there, but in mid-range, that's where you're really strong. So we should see these lines kind of come up and come right back down. It's ascending, descending curve. Now, if we have somebody that has significant patellofemoral pain, we'll usually see a little double hump as they get that increased pressure on the patella and they reduce their torque. When we see somebody with a quad tendon graft, this line will be a little bit less vertical and be a little bit more of a slant. But looking at her graph, all we're really seeing is just a difference in strength. And staying with the concentric side right now, we have numbers for peak torque and work. Peak torque tells us the difference between the most torque they could put out there versus, say there, versus work per repetition, the next row down. That's looking at the strength over the entire range of motion. So I usually look at both of these, right? If we're looking at just peak torque strength concentrically, there's a 53% difference side to side. Work per rep, so the entire range of motion, there's a 52% side to side deficit. Looking at the percentage of body weight, we want about 90 to 100% of the body weight here. She's at 83 with the right and 39 with the left. So even though when she was doing the isometric test with the quad, she was at 67% of her body weight with the with that surgical side. When we go to concentric, now there's a few other elements, right? You're naturally going to be weaker because you're using some of your energy to catch up to the speed of the machine. But now that tendon, her graft site, is being it's contracting and it's shortening, right? So you got that element. You also have the element of the joint mechanics. You have elements of neurologic drive. So it's a lot more complex with concentric. So that's why we see it went from 67 to 39%. So that's okay there. Now, eccentrically, over on the right side, what we're looking at, this is 10 degrees. So the knee is out straight. And what she's doing, she's pushing up as that machine is forcing her knee down through flexion. So it goes from 10 degrees, not much torque, but as her knee bends to 90 degrees, we see more and more torque on that right side. But if we look at the left side, not only is it significantly weaker, but we have these wobbles, this torque unsteadiness. They also call it quad steadiness or force inhibition, oscillation. There's a lot of different words you can use for that. Essentially, her neurologic system isn't responding because when you're pushing up and the knee is bending you down, we're going to start activating the Golgi tendon organs, the muscle spindles. That's going to feed in, to the muscle contracting back down, right? So there's an active inhibition. And it's essentially, she just hasn't been trained through it deeper than about 45 to 50 degrees. So as, you could take this information and say, okay, you're contracting really well to about that point. That's about the height that we typically do step downs to. Then you would use that to say, all right, let's start working that deep range a little bit more. So you'd either go, you do partials on the knee extension machine. You'd work heavier in that deeper range. You could do step downs from a higher height, anything to start activating that deeper range. Lunges, Bulgarian split squats, all those different things that you could program for that. On the machine here, what we're doing is we're just working her through that deeper range. The other thing too is that the deeper we bend her knee, that's more that it's activating or hitting that graft site. So there's an element of pain inhibition with that as well with her, okay? So that's why we're seeing that here. It's not uncommon, especially for quad tendon grafts, even at 6 months out for us to see this, okay? So if this is what your athlete is showing, it's not the end of the world, right? It's common with that quadriceps tendon graft site. So if you look at the numbers for eccentric, it pretty much mirrors her concentric here. 52 at peak torque, 54% difference side to side throughout the entire range of motion. Looking at percentage of body weight, I want her to be about 115 to 130% of her body weight eccentrically. She's at 110 for the right and 52 for the left. All right, so this will increase as just simply from her working through that deeper range as that graft site starts to mature and start condition. So we'll see that naturally go up over the next 4 to 6 weeks as she starts working on these deficits. The next thing I look at is what is the ratio? And this is the ratio of the eccentric to the concentric. You should be 30% stronger eccentrically than you are concentrically. So I'm using the work for this just to hit the entire range of motion. The right side, she's 32% stronger, and the left, she's 25% stronger. So she has a good neurologic balance. It's just she's getting that inhibition there. Next, I'm going to scroll down to the hamstrings. And just like with the isometric test earlier, we see a lot more symmetry here. This is a concentric, so this is with the knee out straight on this left side of the graph, and she's pulling down as the machine is moving her down, right? Versus eccentrically, she's starting here at 90 degrees. She's pulling down as that machine is straightening out the knee. So it's torque with lengthening, okay? Looking at the numbers concentrically, at peak there versus there, she's 15% stronger. But over that entire range of motion, it's only 7%. So we have good symmetry here. But then we look at what is the percentage of body weight. I want this to be about 60% of the body weight. Just like with that isometric test earlier, we'll see that naturally come up as she starts to engage that posterior chain a little bit. So I'm not worried about there. Now, eccentrically, she's 20% different at peak torque there versus there, and only 8% through the entire range of motion. But one thing to note here as I zoom in, your hamstrings, as they're being elongated, should be able to generate torque all the way through 10 degrees. So we normally would expect to see this line, just like the blue lines here, to increase further and further as we near full extension. Now hers, on her surgical side, it comes up and then it kind of stays flat, right? So we'd want to make sure that we're working, loading through that end range. Now, at least what she's not doing, and what we commonly see people with, they have hamstring strains in the past, or if we're working on them for a hamstring strain, is in the last 30 degrees or so, this torque won't not just stay steady, but it'll actually sharply dive down, meaning that that muscle gives out as it's being elongated. She's not getting that there. But what we should expect to see is that this line, when we retest in about 2 or 3 weeks, is that this line stays nice and steady and builds as we go. So nothing to worry about really with the hamstrings. That will naturally come in her next few phases of rehab as she gets more into the strength and conditioning. Let's see. Her neurologic balance, she's only 19% stronger on the right eccentrically compared to concentrically, and 17 on the left. Again, we want that to be about 30%, and that will naturally get better as she's loading more through the range of motion to that end range. Lastly, we have the hamstring to quadriceps ratio, and there's a couple ways we do this. Let me go to her chart. So I give this to you isometrically. So we look at it from an isometric standpoint. Her involved side is at 63%. Her uninvolved is at 42%. We want it to be 60 to 70, and that just comes from her uninvolved hamstring not being as strong as her overly strong quadriceps there, okay? Now, when it comes to the isokinetic test, there's a couple ways we can do this. One is the standard ratio, where I take your concentric number and I compare, concentric quad versus an eccentric hamstring. And those should be a 1-to-1. That's called the functional ratio, meaning your quadriceps concentrically accelerates the tibia and foot, and the hamstring has to be able to eccentrically decelerate that. So we want the motor and the brakes to be equal. So we would want that to be 100%. Well, for her involved side, she's 128. That's just because her hamstring is eccentrically stronger than her quadriceps is at this time concentrically. So we'll see that start to normalize. Now, for her uninvolved side, though, remember she has that overly strong quad and an underdeveloped hamstring at this point. So that's why we see that being a little lower. The other way we can look at this, I don't look at it as much, but I usually put it on. I'm not sure why I didn't put it on for her, is the standard ratio. And that's the concentric hamstring relative to the concentric quadriceps. And that should be a 60% ratio. that pretty much is the same thing that we're looking at isometrically. You want it to be 60 to 70-ish%. So essentially, this is what you will receive from me whenever you send somebody in for testing. I will send you the actual reports themselves. I will also, we didn't do a force plate test on her the first day. I waited a couple weeks to do that because she is working with me, and she really hadn't started jumping yet. So when I'm doing force plate testing, I do bilateral and unilateral. If they've done a unilateral jump, she hasn't done a lot of that yet. So for this is just a bilateral counter movement jump on our force plates. And the data that we're finding with this is that on the eccentric lowering, she's actually loading about 10% more on that left leg. But as she's coming up her mean concentric force, she's doing 22% more on that right side. And this is the averaged over the 3 reps we took. Next, I look at what is their peak takeoff and their peak landing forces. And her on takeoff, even though she's she's loading 22% more as she comes up, but at peak force, it's 19%. So we are asymmetric. We want you to be within 10% on that. Now, when it comes to landing, though, her first 2 reps, she was more on her left within symmetry, but on her 3rd rep, she really landed much harder on that right side. And again, the right side is that surgical side. So because of that, it did put her only within 7.3% more on the right, but this is kind of an inconclusive. It'd be one thing if she had 3 reps that kind of closely mirrored it, but she had that 1 rep on the right side at 38% landing that skewed it. I'd say, if anything, she's pretty close to symmetry except for that 1 repetition. We're going to retest that again in a few weeks when I do her full reevaluation. I've been working with her for 3 weeks since this initial testing. At that point, we're also going to do a unilateral jump. And with unilateral jump, I not only look at the concentric and eccentric mean forces, the takeoff and the landing peak forces, but I look at what's the difference in jump height side to side, what is the RSI, or basically the rate of torque development side to side. Because I didn't test that with her, I just don't have an example to show you with that. So again, thank you very much for watching this video. Essentially, this is what you're going to get whenever you send a patient to me. And if you ever wanted any more insight on, what are some interventions we could do to work on these, you can always get a hold of me. But what I'm not going to do is tell you what you need to do. But I really make it more as, if this machine and these force plates were in your clinic and I was working for you, this is the set of data that you would receive. And if we were to have that conversation within your clinic about different interventions, we could have that. So I want to really make it seem more, be more as like a partnership where we're working together to help your athlete get that return to sport safely without suffering that second injury. So thank you again, thank you very much again for watching this video, and I look forward to working with you and your patients. Thank you.